Welcome to episode 2 of a fully integrated BHC, brought to you by a champion team using rapid cycle QI and other fancy tricks to bring team care science to the trenches. Episode 2 focuses on training in the areas of roles and responsibilities and teamwork, essential ingredients in fully integrating our medical behavioral health services. But fully integrated? What does that mean? In fact, research on integrated care has been going on for some 40 years, but its rigor suffered because people saying integrated meant different things. And so along came C.J. Peek, who created a lexicon for talking about integration. Domain 1 is workflow. How does a practice identify, track, and coordinate care for patients with known behavioral health needs? Clinical services describes the relative presence of behavioral health clinicians and the variety of services that are available. The workspace domain describes the physical location of behavioral health consultants and their sharing of documentation and patients' charts with the rest of the primary care practice. Integration methods refers to how the behavioral health consultant exchanges information with medical clinicians. Identification of needs refers to how screening routines are used to identify behavioral health or behavior change needs within the practice. Finally, the patient engagement domain focuses on the engagement and retention of patients in behavioral health services. Are you sleeping? Okay, we get it. It's a little pedantic, but our initial screening within this practice showed we were less integrated in terms of how we coordinate care, identify patients who need behavioral health, and engage patients. In response, we have espoused a fully integrated model of care known as Primary Care Behavioral Health, or PCBH. A few of the hallmarks of a PCBH model of care include a highly accessible behavioral health consultant who is highly productive, provides a lower intensity of care, and, like the rest of the providers in primary care, sees all comers in a generalist model. But who is appropriate for referral in the PCBH model? Everyone is. Just like primary care, the BHC in this model acts as a gatekeeper to specialist services. Moreover, the BHC can do more in the low-dose intervention in primary care than you might think. So, what can you do to help us deploy the PCBH model at Johnson City Family Medicine? First, pull up a chair in the atrium. Welcome us to hear your precepting session and challenge us to find a way to help. Second, acknowledge the BHC's role in scheduled patients as you huddle. And finally, introduce us to your patients the day they are in to see you. We call this a warm handoff, and that means introducing us to your patient as an important part of a total treatment package we offer here at our clinic. Warm handoffs often happen after the providers visit with the patient and they discover a behavioral need, but nursing staff and front desk staff often have a good sense of when a patient might need to meet with us too. Never hesitate to catch us in the hallway and give us a heads up. In coordination with the medical provider, there are times when it makes sense for us to meet with the patients before they do. And so we conclude episode 2. Goodbye, silos.